I have the privilege of introducing Dr. Katie Satrom, who also spent time here in the Windy City. She attended medical school at the Rosalind Franklin University of Medicine and Science here in Chicago. Afterwards, she moved on to the University of Minnesota for her pediatrics residency and her neonatal fellowship. She has since stayed on to become faculty there. Her research interests have been in optimizing the treatment of neonatal jaundice in at-risk populations, particularly preterm infants and those in low-resource settings globally. Her work has received much attention and support both at home and internationally. Just to highlight one of her many accomplishments, she received a Thrasher Early Career Award for her Global Health Collaborative Project with Nigeria in utilizing smartphones as phototherapy irradiance meters for neonatal jaundice. Today, she'll be speaking to us on the new hyperbilirubinemia guidelines. I'd like to quickly remind everyone to mute themselves. We will have time for Q&A at the end, so if you have any questions or comments, please feel free to share them in the chat box, and I will bring them up at that time. Without further ado, please join me in welcoming Dr. Katie Satrom.
All right, thanks so much. We are, going to be talking about the updated guidelines and then also spending a little time talking about preterm infants, since we take care of both of these populations. And really, as neonatologists, a lot of what we do is manage preterm infants with jaundice and phototherapy. So our talk will be split a little bit into two. I have no disclosures. So again, here are the learning objectives. Split into two halves. So first we'll talk about the AAP clinical practice guideline update from 2022. You all are, I'm sure, aware of the new guidelines, although what I'm seeing from really around the country is that there's a lot of variability in how these are being implemented. So I want to take some time to give you guys the evidence for why the changes were made so that you can better implement them where you're at. We'll also talk about the AAP's current quality improvement initiative, which I'm co-leading on improving the standardization and implementation of these guidelines. And then again, second half, we're going to talk about hyperbili in the preterm population. So what are the unique characteristics of preterm infants, why they're at greater risk of hyperbili, and why we don't have standardized guidelines for them, and how you might approach their management. Okay, so here's just a quick trip down memory lane to give you guys some perspective on how far we've come in terms of hyperbili management. So, for example, the first exchange transfusion for hyperbili was performed in 1949. And then we have the first report of sunlight lowering bilirubin levels was published in the Lancet in 1958. The first study on the use of phototherapy for hyperbilirubinemia was published in Pediatrics in 1968. Then we have the formation of a few different important committees, including the first clinical guideline in the AAP practice parameter that was published in 1994. And then we have the updated or clinical practice guideline that was published in 2004, and that's what we were using up until recently. And here we are now. It's been over a year since this publication came out, and we'll really start there with our talk. So the AAP has this clinical practice guideline committee. They worked from 2014 to 2022, so almost 10 years, to review new evidence and clarify and improve the 2004 guideline. They also reviewed previously unaddressed topics. So phototherapy associated adverse effects is something new that they added to the guideline, and we'll talk a little bit about that too. Here are the main points I'll be discussing regarding the new CPG, so big updates or changes. Again, I don't have time to go through the whole guideline, but this is sort of what's new, what's interesting, and what will pertain to you guys as you practice neonatology. So the biggest change, as you know, is that the treatment thresholds for both phototherapy and exchange blood transfusions were all raised by about 2 milligrams per deciliter overall. And we'll review these, the evidence behind these decisions in a minute. So as a reminder of what the old graph looks like for phototherapy thresholds, we used to have just one graph with 3 curves based on a combination of gestational age range and the presence of risk factors. So we no longer have these low, medium, and high risk categories. You might work with some people that still talk about these risk zones, but they're really kind of old news at this point. Instead, hopefully this looks familiar to you, we have new phototherapy thresholds. And instead now they're on two separate graphs. So one graph is for a patient without neurotoxicity risk factors. So you can see this is what I'm showing you here. There's a one for a patient with one or more neurotoxicity risk factors. And you can see here that there's a different curve for every week in gestational age. So no more grouping a 35-weeker with a 37-weeker, which you guys, again, as neonatology folks, know that that doesn't always make much sense. And then also gestational age is baked in as a neurotoxicity risk factor. So when you're deciding if a patient does have neurotoxicity risk factors, this is referring to anything other than gestational age. The other change is that they did extend the graph to include 7 to 14 days of life. Here's a graph to use for patients, again, with one or more neurotoxicity risk factors. Again, gestational age is built in. And then we have two additional graphs for exchange thresholds. These thresholds were also increased by a small margin. Again, one with a patient with no neurotoxicity risk factors and another with. And so where do these updates come from? And this is, information that you can use, maybe you work with people that aren't quite on board with increasing these treatment thresholds. So they're still based on expert opinion, but are based on evidence that bilirubin encephalopathy and associated long-term complications don't occur until well above the 2004 thresholds for exchange blood transfusion. So some key studies include a large cohort from Denmark. So over with 224 of the whole cohort, which was almost 500 or over 500,000 patients, had a total serum bilirubin over 26. And of those patients, only 3 had evidence of kernicterus. These patients all had evidence of hemolysis. You can see 2 with ABO, 1 with G6PD. And these patients had extremely high peak bilirubin levels, so like 40s to 50s range. Then we have another large cohort from Northern California. This cohort, again, 525,000 patients, only 47 had a TSB over 30. And among these, 3 had evidence of kernicterus. Again, these patients all had hemolysis. So you can see two with G6PD and 1 with DIC. In this cohort, they found that the risk of developing cerebral palsy or hearing loss occurred at over 10 milligrams of bilirubin level, over 10 milligrams per deciliter above what the 2004 exchange threshold was. So therefore, the conclusion was that we were over-treating patients with the previous thresholds. And part of the concern with over-treatment is the possibility of phototherapy-associated harm. So one new aspect of the 2022 publication I referenced earlier was the review of evidence of phototherapy-associated adverse effects. You can find this in the technical report, which is a separate publication. And really the biggest concern over recent years has been the small but significant association between phototherapy and an increased risk of childhood seizures seen more commonly in boys. There's 2 key studies here highlighted. And then other associations were reviewed in this technical report, which included developing atopic dermatitis, autism spectrum disorders, skin lesions, cancers, and phototherapy's effect on breastfeeding and family bonding. But beyond the risk of childhood seizures, these other conditions either had inconclusive or insufficient evidence to prove an association. But despite this, there remain these sort of unanswered questions, and therefore we should avoid overtreatment when possible. And kind of speaking through these treatment thresholds, I did want to say a quick word about risk factors, as I see these confused a lot in practice. So there are several risk factors for the development of hyperbilirubinemia, and those are outlined in this table I have highlighted with that yellow square. So, a sibling who required phototherapy, an exclusive breastfeeder, excessive bruising, or a cephalohematoma. However, it's only the neurotoxicity risk factors in this table down below that actually change your treatment threshold. So here's another look at these neurotoxicity risk factors, and they're slightly different from 2004. So here you can see the previous neurotoxicity risk factors: hemolytic disease, asphyxia, lethargy, temp instability, acidosis, sepsis, and hypoalbuminemia. And now instead of asphyxia, lethargy, temp instability, acidosis, they've lumped all those together to just talk about or to refer to a significant clinical instability in the previous 24 hours. So it leaves it a little bit more vague, a little bit more open to interpretation. And you can tell already that, a general pediatrician might have a really different view of what clinical instability is compared to a neonatologist, for example. So you can use some of those old factors, so acidosis or lethargy, for example, but really it's sort of provider dependent on what clinical instability means. I will say, and we'll touch on this a little bit later, but think of clinical instability as anything that might make you more susceptible to bilirubin toxicity. So bilirubin crossing the blood-brain barrier more easily, changing bilirubin's binding capacity. So I would argue that, a patient on CPAP, that doesn't make them more susceptible to bilirubin-induced neurotoxicity, even though that's technically an unstable patient from like a general pediatrics view. That doesn't really change a patient's risk for developing kernicterus. So I try to think about that physiology of bilirubin crossing the blood-brain barrier a little bit and helping me determine. So the next change from this publication is the new terminology and the new clinical algorithm of escalation of care. So this is a very neonatology specific recommendation. So the threshold for needing escalation of care is defined as a total serum bilirubin level that is 2 milligrams per deciliter below the exchange transfusion threshold. So this is considered a medical emergency with the goal of preventing an exchange and preventing kernicterus. So the CPG says that these infants are optimally managed in the NICU. And if a center lacks access to a NICU or neonatologist, they should pursue a transfer. This is figure 4 from the publication. I won't go through every point, but basically, if a patient isn't already in the NICU, they should be transferred there. In the meantime, they should start intensive phototherapy and hydration. So like if you're taking a transport call, for instance, a patient's at another institution, you can start some of this work with intensive hydration, intensive phototherapy as they're getting ready for transport and actually on transport. Stat labs should be sent. So these include beyond the bilirubin level, things like CBC, serum chemistries, type and screen. You want to notify the blood bank. That's the slowest thing to happen with an exchange. You get all ready, you're nervous, and then you're waiting for hours for the blood to actually come. So notifying them in advance is helpful. And then really just follow the algorithm. So if your TSB is below the level of escalation of care at any point, then you just go to the regular phototherapy guidelines. If you aren't, if you're still in that escalation of care mode, you just continue, again, the phototherapy and intensive hydration. An important point, if at any time the baby has acute bilirubin encephalopathy, so even if they didn't meet exchange, for example, but they had signs of bilirubin neurotoxicity, ABE on exam, that's an indication for an exchange no matter what the bilirubin level is. Or of course, if the latest TSB is at or above exchange transfusion threshold, despite doing all these things, you would prepare for an exchange. So I find this algorithm really helpful, especially for us as neonatologists, is that it's a clearly defined scenario that necessitates NICU care. I think it's also helpful because if a patient does not meet escalation of care, then they really don't need all this stuff, right? They don't need IV fluids. You don't need to be checking a million labs. You can feel comfortable with just regular phototherapy management and regular feeding support without a ton of extra stuff. So really de-escalating is probably going to be your focus if you're not in this escalation of care mode. Okay, so now that we know how to initiate and escalate therapy, the new CPG also gives recommendations on when to stop and when to check a rebound level. So the new guidelines offer an option to stop phototherapy when the TSB is 2 milligrams per deciliter below the treatment threshold at the time that you started phototherapy. So not at the time you're thinking about stopping, but at the time that you start. So this is based on evidence from this paper published in Pediatrics in 2019. It was a large retrospective cohort that estimated the risk of rebound hyperbilirubinemia within 72 hours. So that means that the patient again reached phototherapy threshold within 3 days of phototherapy stopping, was 2.5% for infants greater than or equal to 38 weeks gestation, and up to 10% for infants less than 38 weeks gestation. Now, this guideline will require some clinical judgment and sort of a risk-benefit analysis, as everything does, as this rule may be too conservative or too impractical in some situations. So take, for example, here, this patient, a 35-week baby who's DAT positive. So they had a really low phototherapy threshold. They started phototherapy at 18 hours of age, which was a threshold of 7.9. So getting down to a bilirubin of 5.9 at, maybe day 3 of life might be pretty difficult. So you might want to have a different plan. Maybe you stop phototherapy at a higher TSB than you normally would, but you get a rebound bilirubin or maybe an earlier outpatient follow-up visit. This patient is really different from example 2, which is a term baby, no hemolysis. They started phototherapy at 96 hours of life. At that time, the threshold was 21.5. So this baby was probably kind of at their plateau. And so this patient, you would only need to drive your bilirubin down to 19.5 to meet that recommendation for discharge or stopping phototherapy. So again, about 2 below the treatment threshold at the time of starting, but use your judgment and really think about the risk factors for the patient. And that brings me to the next topic, which is the use of rebound bilirubin levels. So the new guideline also addresses this. So a rebound bilirubin is referring to repeating the bilirubin measurement after stopping phototherapy. So the guideline says that for the low-risk patients, you should wait at least 12 to 24 hours after stopping phototherapy to allow sufficient time to demonstrate whether there's a rebound or not. So earlier than 12 hours is really too early to know whether you're actually going to rebound or not. The longer you wait, the better, in their opinion. So the babies that are going to have rebound hyperbilirubinemia are patients who are at higher risk. So they needed phototherapy in the first 40 hours of life. And these are the patients with hemolysis. So these babies over here should really get a rebound bilirubin, 6 to 12 hours after stopping, and then also the next day. All other patients, so those who were readmitted for phototherapy and all the low-risk patients during the birth hospitalization, they really don't need a rebound bilirubin check. So I know we all kind of get into this mode where we have to check a bilirubin after we stop before sending the patient home. But the data would say that these low-risk patients, so they did not need phototherapy in the first 48 hours. They're not hemolyzing. It's probably mostly suboptimal intake jaundice. They can just get a bilirubin check the next day, which means you can just send them home and have them see someone the next day. Now, of course, follow-up gets tricky, and we'll talk about this a little bit. You need to make sure that they can actually see someone, they're reliable, it's feasible for the family. But that's the recommendation. So not to keep them in the hospital for another check. And then we also have new recommendations for post-discharge follow-up. Now this is the algorithm. It's the figure 7 from the publication. This is only for infants who did not receive phototherapy. So again, we were just talking about rebound bilirubin levels. Those are for patients who were treated. This is for patients in the birth hospitalization. So let's say they had their screening TSB or transcutaneous at 24-ish hours of life. This table is what's going to tell you when they need outpatient follow-up. So I'll zoom in here in a second so you can take a closer look. But this algorithm is based on how many milligrams per deciliter away from the patient's threshold at the time of discharge. Again, so it's kind of confusing. The rebound or the discontinuing recommendation is based on how far you are away from your treatment threshold when you started phototherapy. This is based on how far away you are from treatment threshold at the time that you're going home, at the time that you got this bilirubin level. So here's a closer look at these thresholds. So at the top, you can tell here there isn't much of a difference between a patient's bilirubin level and the treatment threshold. So you can see here it's less than 2 milligrams per deciliter below the threshold. And then your age, so the patient's less than 24 hours, you actually might delay discharge. You might actually consider starting phototherapy depending on how close they are to the threshold, and you really should repeat your bilirubin measurement. However, as you can see, the larger the difference between your bilirubin and your treatment threshold as you move down the table, and in an older patient, the more leeway you can have with the discharge follow-up. So for example, here, if your bilirubin is, let's say, 6 below the treatment threshold and your patient is 60 hours of life, they would follow up in 2 days of discharge. If they were even older, if they were over 72 hours of life, then you could use your clinical judgment. And that's sort of the shared decision making with the family, how easy it is for them to follow up, kind of other risk factors, physical exam, and things like that. The evidence for these follow-up recommendations came from a study that looked at the distance of TSB from the phototherapy threshold and the odds of exceeding phototherapy threshold within 24 hours, within 48 hours, or ever. So this group looked at almost 1,500 infants from this Kaiser Permanente network from 2012 to 2017, and they found a 1.8% of this cohort exceeded phototherapy threshold post-discharge, with a predicted probability of exceeding phototherapy threshold, of 56%. You can see in this top line here, 56% if your pre-discharge TSB was within 1 of threshold, and then all the way down to like 0.0008% if you were 7 below threshold. Okay, so lastly, we do have a new recommendation for when it's appropriate to prescribe home phototherapy. The 2004 CPG did not have a true recommendation for the use of home phototherapy. There was only this short little paragraph at the end of the publication that basically advised to use caution with it due to variability with devices and reliance on families to use an appropriate way. But this new guideline acknowledges that home phototherapy may be less costly, less disruptive to family routines, less stress, and improve family bonding. So patients who would qualify for home phototherapy should all be low risk. So the characteristics are outlined in this slide, but basically the older the infant, no risk factors, whose Billy level isn't more than 1 above the phototherapy threshold, you could consider prescribing home phototherapy instead of intensive inpatient phototherapy. And then, of course, caution is needed. So the quality might be variable with the devices. It depends on the family's ability to use it appropriately. And then you really need to monitor the bilirubin checks daily. So you need either like a home health service that can check bilirubin, or the family is willing to go into the lab to get that done. And this evidence comes from this JPED study in 2020 that reviewed newborns greater than 35 weeks who were treated with home phototherapy. This was a comprehensive program that included daily lab draws and lactation support. And in this retrospective review, less than 2% of patients required hospitalization, and the risk for needing admission included the patients who are younger in age with a higher TSB relative to the treatment threshold. So that's why the CPG came to this recommendation that it should be used in older patients, again, with a TSB that's no more than 1 from the phototherapy threshold. This is a reminder that not everyone's EMR has been updated with the new guidelines and thresholds. Hopefully by now it is, but and you've probably figured this out by now, but Billy Tool, PE Tools, phototherapyguidelines.com will all get you their recommendations. And then some of these are nice because it will tell you how far away you are from phototherapy, from escalation of care, and then also provide you with post-discharge recommendations. This is one caveat to these new guidelines, that they are to be used here in the United States and other high resource settings. So I say that because I know some of you might be involved with global health work, and hyperbilirubinemia is clearly a global issue. So Dr. Tina Slusher is one of my mentors here at the University of Minnesota, and She and some of our Nigerian colleagues collaborated on this article that was just published this spring in Pediatrics. But basically, they call out that, again, these current AAP guidelines are meant for places with the resources to reliably check bilirubin, reliably provide phototherapy, have reliable follow-up. And really in low and middle income countries, both the risk of severe jaundice is higher with things like G6PD deficiency, lack of ROGAM to prevent isoimmune hemolytic disease, sepsis, all that stuff is sometimes lacking. So just to be aware that if you're thinking with a global health hat on, or you're traveling somewhere for a rotation, you want to make sure that you are using kind of appropriate in-country guidelines. Okay, so quickly, I wanted to introduce you all to this AAP Quality Network project. So the AAP has this, and they renamed it. It used to be VIP, now it's called PAC, the Pediatric Acute and Critical Care Network. Every so often, they do these sort of national quality improvement projects. We are currently working on this project Light, learning and implementing guidelines for hyperbilirubinemia treatment. Probably a lot of you are involved, or maybe at least your institution is involved, but we're working on improving the evidence-based guideline or standardizing the care for the management of hyperbilirubinemia based on these new guidelines. So we have 150 institutions across the country participating. And really the goal for this project, we kind of looked in the CPG and looked for what we thought were kind of the big hitters in terms of improving jaundice care. The biggest aim that we're working on is decreasing sub-threshold phototherapy. We're also looking to obtain DAT, evaluate for hemolysis in all the appropriate instances, decrease unnecessary rebound testing, so not keeping patients in the hospital just for a rebound check if they're low risk, and then decreasing unnecessary IV fluid use. So we're doing all kinds of interventions, education, providing clinical algorithms, EHR tools, lots of QI coaching. And I did just want to show you kind of the baseline data for the national collaborative. This is sub-threshold inpatient phototherapy with kind of the percent of cases being sub-threshold on your y-axis. So you can see here, 50% of all the phototherapy cases, again, this is from around the country, both community hospitals and large pediatric referral hospitals are sub-threshold. So just to give you kind of a taste of the landscape, it's still something that we do a lot. Sometimes it's clinically appropriate. Sometimes a baby's really close to threshold. Sometimes there's barriers in access to care and access to follow-up. And of course, there are going to be times where we need, and it's appropriate to deliver some sub-threshold phototherapy, but it's also this kind of cultural shift with these new guidelines that we have a lot of kind of fear around missing a case or mismanaging a case, and also thinking that phototherapy treatment's pretty harmless, which it's not completely. And so this is what we're continuing to work on. This project will continue through February of this year. So we're going to switch gears a little bit and talk about preterm infants. So what about patients who are less than 35 weeks gestation? Can we have a national guideline for them too? Really, there's a lack of data on the effects of bilirubin and phototherapy in this population, and therefore we see a lot of variability in the clinical management of these patients. So what makes preterm infants different? It's really about both added risk factors and brain immaturity, which makes these patients at risk for developing bilirubin neurotoxicity at lower levels of serum bilirubin. So the first big risk factor is exaggerated jaundice. So as you all well know, pediatric or preterm infants' organ systems are all immature. All the factors that go into the development of physiologic jaundice in the term infant are at play for the preterm, and they're just all very exaggerated. So again, a shorter red blood cell lifespan, so 30 to 60 days instead of 60 to 80 days, impaired conjugation of bilirubin, increased enterohepatic circulation, especially since many of these infants aren't being fed right away. We also worry about increased CNS entry of bilirubin for preterm infants. So the bilirubin binding capacity is likely lower in preterm infants. They have lower serum albumin levels. They have illness factors such as acidosis, hypoxemia, medications that can all displace bilirubin from albumin. The blood-brain barrier may also be compromised, again, due to all those illness factors, inflammation, and then changes in cerebral blood flow. Brain maturity is also at play. So bilirubin primarily affects neurons through oxidative stress, altered neuronal arborization, synaptotoxicity, apoptosis, and proliferating neural stem cells. So young neurons are more susceptible to unconjugated bilirubin. There's also evidence that bilirubin stains in a different pattern in the preterm brain than the classic topography of bilirubin's effects in the term brain. And so classifying long-term neurodevelopmental effects related to bilirubin might be a little bit more tricky. And then lastly, comorbidities. I especially think of inflammation in our population. So there have been studies that look at pro-inflammatory cytokines plus unconjugated bilirubin really increase the activation of signaling pathways like apoptosis in these immature neurons. So for all those reasons, we are extra careful with our preterm babies. And what we know about the increased vulnerability of preterm infants clinically, so a lot of that other stuff I talked about is kind of based on cell culture and basic science work. But what we know clinically comes from data from like pre-phototherapy and pre-exchange blood transfusion era, so before 1955-ish. This table presents these data from Cross et al., published in 1955. Then it was summarized again by Dr. Bhutani in 2016. So these data include preterm infants who survived over 48 hours in the NICU. They did not have significant hemolysis, so this was physiologic jaundice. And you can see by looking on the right-hand corner, the percent cases of kernicterus increases with gestational age, which makes sense. So here we have 10% cases of kernicterus in babies who were in that 30 to 31 week gestational age range. And that's kind of the lowest gestational age at this time that the study went down to. And then you can see overall the rate of kernicterus was 2.8%, of which the mortality beyond the first 40 hours was 73%. So these are pretty huge numbers if you just think about how we really, I'm guessing you probably haven't seen kernicterus in one of your preterm patients. But now, since about 1985, it's been common practice to use phototherapy aggressively after birth in preterm infants, and this has reduced the rate of kernicterus. So here's a study that first looked at the efficacy of phototherapy in preventing hyperbilirubinemia in low birth weight infants, published in 1985 in Pediatrics. This study was funded by NICHD, and it started enrolling patients in 1974 across 6 institutions. It randomized infants to either phototherapy or control. So can you imagine kind of studying that right now, randomizing a patient to just control with no phototherapy, in 3 birth weight groups, including one cohort that was less than 2 kilos. So that's kind of what we use when we think of preterm infants, and looked at the efficacy of phototherapy in preventing hyperbilirubinemia. So here's a look at some of the data. You can see here from table 2. So this is age and bilirubin level for phototherapy and control at time of study entry. So the infants less than 2 kilos are highlighted here in the yellow box. The mean bilirubin at the age of entry at approximately 24 hours of life was 5 to 6. And that's really why it's become common practice for a lot of us to start treating bilies at 5 in this preterm population. It's just, this is what the bilirubins were at 24 hours of life, and they got treated. Figure 1 on your right demonstrates the efficacy of phototherapy in this cohort less than 2 kilos. So the phototherapy group, I have that arrow there at the bottom. You can see their bilirubin levels never really reached above 7, compared with the natural course of a bilirubin, and then in the control group, The peak bilirubin was around 10 and then sort of spontaneously came down. If you're wondering about the safety of this study, each weight category was divided into two groups: a standard risk for uncomplicated patients, higher risk for sick patients. And in order to avoid hazardous levels of bilirubin, there was a max bilirubin set for each weight group, at which point the patient received an exchange transfusion. So patients in the control group, 24% of them required an exchange blood transfusion compared to 5% in the phototherapy group. So for anybody who says that phototherapy prevents the need for an exchange blood transfusion, it's sort of kind of common sense, but this is really kind of where that data first came from. Now, after that paper was published, aggressive and early phototherapy became common practice for preterm infants. So it's really been pretty hard to ethically design a study looking at the effects of bilirubin and phototherapy in the preterm population. So our next clues come from case reports of bilirubin-related neurotoxicity in preterm infants. So that first bullet here, we have autopsy data with one report of a 4% risk of or rate of kernicterus in preterm infants, and also findings of kernicterus and VLBWs with lower TSBs. And we also have MRI data from various case reports that suggest bilirubin neurotoxicity both on imaging and later neurodevelopmental follow-up in preterm infants who only had modest risk, sort of modest peak bilirubin levels, so in the 8 to 12 range. This slide comes from a review called The Enigma of Low Bilirubin Kernicterus by Doctors Watchko and Maisels. And this table is a nice review of the case reports I just mentioned. So looking at the top, they looked at risk factors, so hypoalbuminemia, comorbid CNS injury, and infection or inflammation. And then you can see here that the majority of cases had at least one risk factor present, and half had two or more risk factors present. But you can see here the gestational age on the far right. These are 24 to 30 weekers-ish. And these patients had peak bilirubin levels in like the 8 to 12 range. So given these historical data, our current guidance for the management of hyperbilirubinemia in the 28 to 35 week gestational age preterm group comes from this expert opinion by Dr. Maisels, published in Journal of Perinatology in 2012. Again, these data come from what I just reviewed, and it's really kind of expert opinion. There haven't really been studies to prove this one way or the other, but it's sort of the agreed upon numbers to prevent this low bilirubin kernicterus phenomenon. Here's another look from the same information. It's from Bhutani review. The shaded bands represent the degree of uncertainty and where we should use our clinical judgment based on risk factors. And for those of you who use the Stanford Preneability tool to help you decide about treatment for these patients, that's where these numbers come from. So we just reviewed recommendations for the 35 weeks and older group. That's the new CPG from the AAP. And then we just talked about the 28 to 35 weekers, but what about the extremely preterm group, the less than 28 week group? So the data are not clear cut. This slide reviews a few studies looking at neurodevelopmental outcomes for preterm infants with hyperbilirubinemia. Most of these studies included infants less than 32 weeks, but for many, the mean gestational age was in the 26-week range. So for each of those studies, I have the mean gestational age highlighted. The left-hand column here highlighted for you lists 3 studies that demonstrate increasing risk of neurodevelopmental impairment with increasing total serum bilirubin levels. However, the right-hand column highlights other studies that either demonstrate no difference in outcomes based on degree of TSB or actually a negative association between aggressive phototherapy and the associated lower bilirubin levels and outcomes. For example, worse ROP with prolonged phototherapy and low peak bilirubins, and then the Morris paper, which you all probably are aware of, that NRN trial that demonstrated increased mortality in the aggressive phototherapy group for infants less than 750 grams. So again, the data are mixed. We've looked at this at our own institution and have some interesting data that we're in the process of publishing in a retrospective review of infants less than 32 weeks, their mean gestational age 29, 27 and a half. The infants who had a longer duration of phototherapy had associated lower cognitive scores on their Bayley scales of infant development at 1 and 2 years corrected age. So this association was after controlling for both the bilirubin level, so peak TSB, the degree of illness, and their SNAP score, gestational age, and weight. And you can see here that the significant effect was in the motor subset of the Bayley, but you can see a trend toward significance in the cognitive and language subsets, and overall their composite was lower. So there's some worry that sort of clearly we want to prevent bilirubin neurotoxicity. That's the number one goal, but we also want to limit unnecessary treatment. So why might we be seeing these negative associations? That brings me to my next point, which would be to discuss bilirubin as a protective antioxidant. This antioxidant property of bilirubin is what is speculated to be at play in these studies that found this negative association between low bilirubin levels and outcomes such as ROP or mortality. There's a good deal of literature, both basic science and clinical, suggesting that bilirubin has a cytoprotective role in its ability to quench reactive oxygen species. So we know that bilirubin is a byproduct of heme. It's broken down by heme oxygenase to biliviridin, iron, and carbon monoxide. You can see that here in that little graphic. And then biliviridin is reduced to bilirubin, which is then available in this redox cycle, whereby bilirubin captures lipophilic ROS, gets oxidized back to biliviridin, and then detoxifies excess oxidants, and ultimately protects membrane lipids from injury. So cells likely have this bilirubin recovery pathway as a way to maintain antioxidant homeostasis. Clinically, mild to moderately elevated bilirubin levels in cohorts of adult patients. So the classic cohort is patients with Gilbert's disease or other polymorphisms of the sort of enzyme that conjugates bilirubin in the liver, have evidence of improved outcomes in diseases such as cardiovascular disease, progression to end-stage renal disease, autoimmune diseases, and some types of cancer. So it's kind of the background or the groundwork from which we're talking about bilirubin as a protective agent. But what about in the newborn period? So I already mentioned that phototherapy lowers bilirubin levels, may cause or increase the risk of childhood seizures in term babies. And then I also mentioned a randomized clinical trial demonstrating that aggressive phototherapy and lower serum bilirubin levels was associated with increased risk of death. So it's the MORA study. And there have also been studies that look at peripheral markers of injury related to phototherapy that have found associations between phototherapy and markers of oxidative stress and DNA damage in the blood. I did want to say a quick word about cycled phototherapy. So there's this publication I'll highlight here, and then I believe some of this work is ongoing. But in response to these concerns, this study was performed to compare cycled phototherapy to continuous phototherapy with the goal of preventing any phototherapy-associated morbidity and mortality, but to also keep the mean peak TSB levels in a reasonable range. So this study randomized patients to cycled phototherapy, which was 15 minutes of phototherapy in an hour, against continuous phototherapy. This was using all LED devices. The study was conducted across 6 centers. You can see here the difference in hours per day of phototherapy. On the y-axis is hours per day, on the x-axis is time in days. So clearly, cycled phototherapy group gets less phototherapy in a day. You can see that here in the table. So they're comparing mean TSB levels, which are not statistically different. So 6.4 versus 7.1 in the cycled group. And then clearly their mean phototherapy hours is less. So 34 hours in the cycled group and 72 hours in the continuous group. And then the secondary outcome of mortality was not different between groups. And then one center also looked at brainstem auditory evoked response, which was similar between groups at 35 weeks corrected age. So looking at that more functional outcome of bilirubin induced damage. So I guess my point in a lot of this is that there's still a lot of unanswered questions in how we appropriately treat preterm babies. That's really what drives my research program, which is focused on untangling the toxic and beneficial effects of bilirubin using both preclinical and translational models. So because the preterm population is complex and the patients have many risk factors for neurodevelopmental impairment, also because the standard of care is already sort of set at preventing hyperbilirubinemia in these patients, we really need to go back to some other methods of research to get tease some of this out. And this is really probably a whole nother talk, but I wanted to introduce you to a couple of ways that we can go about this and introduce you to these models in case you come across them in literature review. So one is a gun rat model. So gun rats have a spontaneous deficiency in the UDP glucuronoltransferase enzyme, which is responsible for conjugating bilirubin. Homozygous pups develop mild hyperbilirubinemia. Heterozygous pups are non-jaundiced and they serve as controls. And if you want to sort of have a model of exaggerated jaundice, there are publications that give this sulfonamide, which, as you know, sulfa displaces bilirubin from albumin. It increases the transfer of bilirubin across the CNS, and it causes this classic kernicterus model. Sulfa injection on P16 is what has been classically used in the literature. And then we and others have published a preterm model of sulfa, giving that on postnatal day 5. So in more of a preterm brain development window. We've looked at region-specific effects, so cerebellum and hippocampus. We've looked at structural effects using immunohistochemistry as well, and then looking at metabolomic and gene expression profiles and how they differ between groups. And again, I won't go through details, but really this is just to give you an idea of how you might go about answering some of these questions that are hard to answer at the bedside. So in this, you can see in these MRI images, even without knowing a whole lot about the study, this is the cerebellum on the top of a control rat and on the bottom of a jaundiced rat. This is more of a severe jaundice model. You can see that cerebellar atrophy there in the red square at the bottom. Again, so here's sort of the model. We can also give phototherapy to the rat. So that's something that we've looked at, giving phototherapy or not phototherapy, and then looking at things like RNA sequencing of different regions of the brain, looking at differentially expressed genes in rats who are jaundiced and not, and rats who receive phototherapy or not. The one thing I want to point out to you with this study is that if these are the number of differentially expressed genes in the hippocampus, you can tell that phototherapy alone led to over 3,000 differentially expressed genes compared to about 1,300 for jaundice alone. So there's something about this treatment with phototherapy that's affecting the brain that's independent of its role in lowering bilirubin levels. We also tried to get at this with phototherapy and looking at plasma metabolomics in preterm infants. So enrolled preterm infants, they got phototherapy just based on provider, their provider discretion, how they normally would treat. And then we collected samples of the plasma before and after phototherapy, and then used metabolomics, which is this process of identifying small molecules or metabolites that may provide information on sort of the combination of genetic, environmental, microbiome, all those factors, to understand more of a phenotypic information. So you can see here, this is sort of the metabolomic profiles distinguishing groups, gestational age, and phototherapy. The metabolomic profile of the plasma before and after phototherapy is distinct again, and these this is after correcting for total serum bilirubin level. So it's a potentially independent effect of phototherapy. And you can see here, this is a similar Venn diagram to what I showed you before from the gun rats, but this is in our Humans, this is plasma. Again, phototherapy affecting 664 significant metabolites compared to 191, which was just the gestational age alone. Again, this is after controlling for bilirubin levels. So I'm going to pause here. So as I wrap up, these are some kind of key take-home points I think we can all use as we get back to the hospital. The first is really to use protocol-based management whenever possible. So if it's your 35-week and older patient, please use the AAP clinical guidelines. I'm sure you're all using them. Maybe you need to encourage your colleagues or your attendings to be using them. For preterms, we have less guidance. But really using some type of standard approach within your group or institution is helpful. We should be performing a proper risk assessment for all patients. Remember to take into account age and hours and the neurotoxicity risk factors when plotting your patients in the AAP treatment thresholds. And I would advocate that preterm infants also deserve a nuanced risk factor assessment. In my sort of practice and in my experience, for preterm infants, we just say, oh, their bilirubin's 5 or 7 or whatever, let's treat. But really, you should think through the same things. Is there hemolysis? Is there inflammation? What's the rate of rise? All these other important factors. You know, prescribe phototherapy like a medicine. So that kind of gets at all these potential negative associations. Even though in general it's fairly safe compared to a lot of things that we do, it still deserves the care and prescription like we would do a medication, not just to slap it on because it's easy and it's just there to do it. And then lastly, encourage all of us to remain kind of engaged in research endeavors related to hyperbilirubinemia. There's a sense that jaundice management has sort of been solved because phototherapy is effective, it's simple, but especially in the preterm population, there's a lot of nuance and a lot of unknown still. So we're probably not doing it as well as we could be. So again, in all of this, the goal is to prevent bilirubin-induced neurotoxicity without overtreating. So finding that balance is still a little bit elusive. I want to acknowledge all of my mentors and research team and funding. If you wouldn't mind, so we have 2 surveys. This is my own QR code for feedback. If you wouldn't mind taking a minute to fill that out, I'd really appreciate it. It will just help me know how to tailor this talk to the next audience. What you liked, what you didn't like, what you thought would be helpful, what you would change. So if you can just take a second, and then the ONTDP TPD folks also have a general survey at the end. So I'll leave this up for a minute and then I'll flip to the next slide.
Yep, and I've also put the online with the expert evaluation link in the chat. So if folks want to access it that way, that would be greatly appreciated. Well, thank you so much, Dr. Satrom, for a great talk. I learned a lot and I'm definitely going to use phototherapy more judiciously. I think you're right in that it is one of the more benign treatments that we offer, but like everything that like all treatments, there are consequences to them as well. So while everyone's filling out surveys, there were a few questions and comments in the chat. So Laura Colville had a comment. She said, on recent review of Vaughan All Care is brain care benchmarks, and it was noted that being on phototherapy was a barrier to one of the goals in proper positioning in the ELBW and VLBW infants. That makes sense with the data demonstrated concerning lower motor development scores in premature infants who've received phototherapy.
Yeah, that's interesting. I hadn't heard that from the Vaughan data, but that's there. I think that evidence from the preterm population plus the evidence of seizures in the term population just gives these like small clues that there's something going on in the brain that we haven't quite captured.
And then we had 2 questions about management of hyperbilly. The first is, what is considered intensive phototherapy? Like, how many banks of lights?
Yeah, so that is a great question. I could talk to you an hour about intensive phototherapy. So you need to measure a radiance. So you measure the strength of the lights is measured by irradiance. You need an actual irradiance meter. It's a device that you hold, under the lights at the level of where the patient is at. And that number should be 30. So intensive phototherapy is an irradiance of 30 or higher. Um, Whether units, NICUs have an irradiance meter is really variable. So to be perfectly honest, our big level 4 urban center does not have an irradiance meter. For whatever reason, the hospital isn't paying for it. So we use the one that I have for research. But other places have a protocol, and the nurses automatically measure irradiance at the start of phototherapy, at every shift. Like, there should be some type of protocol that your institution has for measuring irradiance, because what you can do is you can adjust the phototherapy based on the level. So if you measure the irradiance and it's only 25, the things that you can do are, the biggest one is decrease the distance of the lights to the baby. Maybe you change the positioning of the baby to make sure it's in the center. But that's another one of kind of my passion projects is, if you're going to use phototherapy, you might as well do it well. And that's with the irradiance, measuring it, optimizing it. But anyway, long story short, 30. You want an irradiance of 30. It's not the number of banks, it's the irradiance, and then how much surface area, I guess, is the other piece. So the top device should be 30. And then if you want more therapy, again, you want to increase your surface area. So putting a blanket underneath, and that kind of adds it on. And it's all about the most intense light comes from the center of the device. So if you have two banks that they're like this, you actually might be totally, like, the maximum light therapy might be actually missing the baby, just going to the bed. So you want to make sure it's as parallel to the baby as you can make it.
Kind of jumping off of that, I remember in residency, we had once lined the baby's bed with a reflective surface. Like, does that actually help augment the irradiance?
It does help augment the irradiance in that from what I understand, it's like physics, but it reflects the light. So any light that gets lost to the surroundings of the baby, like the bedding or whatever, it reflects it back to the baby. So that's what the aluminum foil would do. Other places will just make sure you have like a white sheet or something in there. But that is done to improve the phototherapy. It's definitely done in low resource settings as well if they don't have great quality phototherapy.
Thanks. And I have one last question.
Shoot,
What
you
is
are.
considered total fluid goals for hydration?
That's a great question. Are you are you thinking about like escalation of
Sorry, is
care?
my connection bad?
You're just a little bit glitchy.
Yeah, sorry, in terms of escalation of care.
That's a great question. I don't think anybody knows the answer. I guess I tend to think of at least 20 mils per kilo or more than you normally would for that age. So if it's a 2-day-old and you normally would do 60 or 80 per kilo per day, maybe you do 100 per kilo per day or 120. I think it just depends on the age of life and how dehydrated you think that they are. So yeah, I would say 20 or 40 or more per kilo per day of what you normally would think that they would get otherwise. And yeah, it's just a little bit of a guessing game, to be honest.
Right. Well, thank you so much. Um, and I think those are all